am from the Institute of Neurosciences, Kolkata, and I look after the critical care, stroke medicine, as well as tropical neurology clinics. So we are going to be talking about a very important topic of the role of nurses in the management of a patient who is convulsing, right? But my slide is not moving.
Please use the arrow button.
No, it's not moving. Shall I start sharing once again?
Yes, you can.
So we will be talking about what is a seizure, how do we recognize a seizure, what are the diagnostic tests which we want to be doing, how do we care when a patient is having an active convulsion or he's seizing, what are the medications used and what are the complications, especially of the medications. So a seizure is a sudden uncontrolled electrical disturbance of brain. It is discharged from from neurons of the brain, and that spreads across the brain, and that leads to a lot of motor activity or sensory activity and loss of consciousness at times. So what you see convulsion is a physical manifestation of a seizure marked by jerky movements of part or parts of the body with or without loss of consciousness. When there are two or more seizures at least 24 hours apart that are not brought on by an identifiable cause, then that is called an epilepsy. So ideally, if you ask a neurologist, they will ask you to describe the semiology of the seizure. That is, it has different phases. Typically, a prodromal phase, which involves a mood or behavior change that may precede a seizure by hours or days. Then there is an aura or a premonition of impending seizure activity, which may be visual, auditory, or gustatory. Then there is the ictal stage, which is characterized by the musculoskeletal activity, usually, and that is the convulsion, and the post-ictal period of confusion, drowsiness, somnolence, irritability, etc. But all these stages are usually not seen in case of a patient who is received in the intensive care unit or one who has a seizure in the intensive care unit. So this is actually the preliminary history part of it, because that helps to localize from where or characterize which kind of seizure is happening. Now, what is status epilepticus? Most of us who are in the ITUs will want to be asked to see patients who are in status epilepticus, right? So those with prolonged or rapidly recurring seizures lasting 5 minutes or more and without uh, returning back to the previous state in 5 minutes time is called a status epilepticus, and that needs immediate resuscitation, because the more the time it goes on, the seizure activity, the secondary brain insult takes place. So as you know, in intensive care, neurocritical care units, apart from the primary brain injury, we are also more concerned about the secondary brain injury, which goes on because the primary disease process causes a lot more damage to the other active or the healthy neurons. So in neurocritical care, the term secondary brain injury is of utmost importance. So as we go on with the initial diagnostic steps, in parallelly, we should not delay treatment of the convulsing patient, right? So status epilepticus is 5 minutes or more of continuous clinical or electrophysiological seizure activity or recurrent seizure activity without recovery, that is returning to the baseline between the seizures. And emergent treatment is paramount in patients with prolonged seizure activity, as I said. Now, a convulsive seizure is that which contains the typical rhythmic jerky movements of the limbs. Now, a generalized tonic-clonic movements, as we all know, I think most of you have seen, where you have jerky movements of all the limbs. There is impairment of the mental status, coma, lethargy, or confusion. This may lead on, once it stops, there may be focal deficits in the post-ictal phase, like Todd's paralysis, which lasts from few hours to around 7 days. There may be hemiparesis or a monoparesis, which usually recovers on its own. So, and focal motor status epilepticus or partialis continua are not included in this definition. Now, what is refractory status epilepticus, which continues, for status epilepticus, the first line of management is a benzodiazepine, namely what you know is lorazepam or midazolam. And if it doesn't stop and you add one anti-epileptic drug of choice these days is levetiracetam, and if it doesn't stop at that, we call it a refractory status epilepticus. And what is super refractory status epilepticus? It is an ongoing seizure with more than 24 hours of anesthetic agents like continuous infusion of midazolam or propofol or ketamine, or recurrence of seizures when you are trying to withdraw these medications. That is a super refractory status epilepticus. Now, simultaneously in the intensive care unit, what you need to look at is the non-convulsive status epilepticus. As the word goes, it is non-convulsive. And that is, you don't get this jerky movement of the limbs, right? So how is it diagnosed? When the patient is obtunded, drowsy, not obeying commands maybe, or behaving bizarrely, confused, then you go on and attach EEG to the patient, and then you get the encephalogram or EEG where there are discharges, and then there are criteria to call it a NCAC. Now, two rather distinct phenotypes are the wandering, confused patient presenting to the emergency who has a probably a good, better prognosis, or the patient with severely impaired mental status without subtle motor movements or some twitch of the eye or the mouth that often misses your eye, and these are subtle status, and they all fall in the category of non-convulsive status epilepticus. Now, there may be negative symptoms like patient is aphasic or mute or presence with catatonia, confusion, etc. Or there may be positive symptoms like agitation, aggression, delirium, crying, perseverance, or psychosis, or tremulousness, and these may be part of the spectrum of a non-convulsive status epilepticus. Now, what is a non-epileptic attack, that, like we say, so, or functional attacks? Here you find that the patient is actually conscious or has purposeful movements of the limbs, and these are not coordinated. They thrash back, and if there is a back arching opisthotonus, you can be rest assured that this is a psychological patient who has a dissociation, right, or non-epileptic spell. Sometimes they shut their eyes, refusing to. When you try to open the eyes, they try to resist, and that is once again in favor of a NEA or non-epileptic attack. Now, pelvic thrusting, once again, head rolling or pelvic thrusting is one again almost a sine qua non of a non-epileptic spell. Now, what could be the underlying cause of these seizure attacks? Now, acute processes in the intensive care unit, there can be hyponatremia, hyperglycemia, hypoglycemia, metabolic causes, sepsis, CNS infection like meningitis, encephalitis may present with seizures, strokes, often associated with seizures, traumatic brain injury, most often have been seen to be associated with seizures, drug intoxications, drug withdrawal, or sometimes therapeutic drugs can also cause seizures. Hypoxia, hypoxic brain damage after cardiac arrest, hypertensive encephalopathy. And very common is the autoimmune encephalitis, which present with refractory and super refractory status epilepticus often. And in chronic cases, usually patients are the epilepsy patients who have missed their drugs or not taken their drugs or have have some precipitating illness like fever, a febrile episode, and they may present with convulsions to the emergency. Chronic alcohol use can also do so, and CNS tumors can also present with seizures. And in children, a lot of metabolic errors of metabolism can also present with seizures. So, important as nurses, you must take a history of when the seizure started, how long it has been happening, have they regained consciousness in between, have they got injury, have they hurt themselves, like very violent convulsions can lead to even humerus fracture or fracture of the long bones. They may have scalp injuries, or in elderly they may fall with head injuries. So it is important. Medication history is very important, what all medications they are taking, last when they have taken the medicine, have they been following the proper routine or not. Any fever or any other injury is also important because that may be a precipitating cause. Comorbidities, especially in case of elderly, is like diabetes, because immediately then you would check for a CBG and rule out a hypoglycemia or a hyperglycemia. And whether they had any complications of medications, like phenytoin can cause Steven Johnson syndrome, valproate can cause hyperammonemia, and things like that. So nursing considerations are what you have to be very careful is initial nursing care will immediately begin as soon as the patient enters seizing or at the onset of the seizure activity. Safety is the primary focus. patient patient to be placed in the recovery position, any lateral recumbent position, keep the head end of the bed elevated, pad the sides and rails of the bed, and suction appliances to be kept for prevention of aspiration. Important not to restrain, do not pull or push the patient, or do not insert anything into the mouth. This can cause further injury. Sorry. Furthermore, supplemental oxygen if the patient becomes hypoxic. Always assess their ABCs, airway, breathing, circulation, whether their airway is clear or they need intubation or airway protection. Vital signs, look at the heart rate, whether there is bradycardia or tachycardia, because usually if there is a subtle seizure where there are only eye signs, then you look at the heart rate and the pupils to see whether the heart rate is increasing and the pupils are dilating, right? So that is also one indication that this is an ongoing convulsion, right? And always try to get an IV access as early as possible, because your doctor is going to immediately ask you to push medications. Along with this, simultaneously, you must try to do an initial neurological examination, like baseline level of consciousness, how far it was there, pupils, whether equal or unequal, and whether they are moving one side more or one side less, right? It is important to monitor and document the type of seizure activity, including precipitated factor and description of the seizures, including whether they were complaining of any sensory symptoms or they were behaving bizarre before the onset of the seizure, and how long the convulsion took place. Diagnostics should proceed in parallel with treatment, like you can go ask for a ABG to just rule out hypoxia. You can ask for a sodium or a CBG, and you must also get prepared so that an EEG can be done, or a CT scan, or any kind of neuroimaging as and when required. Communication between if you are working in the emergency department or the intensive care unit, the communication between these two departments has to be very strong. That should include whether the patient was received in convulsion, or what was the type, how long it has been taking place, what they have given in the emergency, what needs to be given later on, and whether after the medication the patient responded, or how long they responded or did not respond, and what is the respiratory status, whether they are breathing, they are having adequate airway, what is about the hemodynamic status, and what else tests need to be done. These need all to be documented and handed over, right? So this is one of the our intensive care unit charts, where you can find that it's a typical neurocritical care unit. You have the pupillary scale, you have the visual analog scale for the pain, and the GCS scores. Then here you have the vitals, heart rate, etc., intake, output, ventilatory parameters, right? So along with that, we have this is the GCS, and here you find the kind of convulsion, according to the time, whether it is GTCS, focal, and how long it was there, and what was the treatment given. So this is how you document. So, and this is just a picture which you all know of a recovery position, how to prevent aspiration in case of a convulsing patient. And this is the bedside EEG, which we have, continuous EEG, and you can find that there is a lot of discharges on the monitor. That means the patient is having active convulsion. Now, I'll ask you to look at this boy who was a known epileptic, but he presented to us with convulsion, and he was on anticonvulsants. And look how subtle the features are. You may miss it, if you don't look at properly. I'll try to run. Look at the eyes, just a flicker of movement, and you can easily miss it, and look at the hands, just subtle movements. He is actually seizing, right? Look at him again. Very subtle movement. Look at the eyes. You will feel as if it is normal, but it is not so. And look at the eyes. There is some rhythm, and the hand, some rhythmic movement of the hand, right? Left hand. So, and look at the conjunctiva. Because of the convulsion, he had a subconjunctival hemorrhage. So this you have to look out for and immediately identify. And these are signs that an ongoing seizure is happening, right? And after that, see, he's going off to sleep. So the seizure activity is almost over. That episode is over. And what was the EEG? We did a continuous EEG. Then look at the discharges in the EEG. And a test dose of lorazepam was given, and all the spikes had gone. So that was a seizure, right? Now look at this lady. You cannot miss all this, even if they are intubated with tracheostomy, you cannot miss this movement, right? She stopped, and then slowly it's going on happening. And then it stopped. See the movement of the eyes, and it stopped. So you cannot miss this movement. And look at her EG. She also had spikes. These are the epileptiform discharges, right? And after a test dose of lorazepam, you achieve a burst suppression. Look at her again. So you cannot miss this movement, right? So these are the things you should look for in an intensive care unit, because patient is not going to announce that I'm going to have a seizure, right? So your eyes must be wide open, and your brain must be alert to pick up any subtle signs. Then only you will be able to pick up these. See, now it stopped. See, just few seconds, and she's dozing. So that's a seizure. Right? Once again, She had discharges, and it goes with anti-epileptic. See, it's gone. Now look at this boy. Is this a convulsion? Almost symmetric movements. He was hyperventilating. He was hyperventilating and sweating. This is actually not a seizure. This is actually not a seizure. It is a paroxysmal sympathetic hyperactivity, which often happens in case of an, in diffuse axonal injuries. And in this case, this boy had encephalitis. So just a question over here. Which of these drugs may mask a convulsion? Amiodarone, atracurium, noradrenaline, or soda bicarb? Can we have some answers, please? Are they allowed to answer?
Yes, ma'am, they can write their answer in the chat box.
If somebody wants to write their answer, they can. Which drug will mask a convulsion? Amiodarone, atracurium, noradrenaline, or sodium bicarbonate? It is actually because it's a muscular blocking agent, so the patient will be paralyzed and you will not find any convulsion happening. So there is something somebody has written. Yes, very good. Once again, it's not moving. I have to once again start sharing again. And okay, now what are the diagnostic work? All patients should have a baseline, monitoring of the vital signs, and the airway is a must. ECG is a must. Glucose, finger stick glucose is a must. A CT scan is usually done in most of the cases, especially if you are in a neurocritical care unit like ours, then obviously we are going to. So by and by, you will order the other laboratory tests like ABG and other electrolytes, calcium, CPK, arterial ammonia, etc. And EEG is a must. Not all centers have the facility of continuous EEG monitoring, so you can ask your regular routine EEG technician to come and do it also. Sometimes we need the serum levels of anticonvulsant agents like serum phenytoin level or valproate levels, because sometimes if you adjust the dosage, then the serum level goes up and it prevents further attacks, right? Neuroimaging we have discussed. You can do an MRI as and when required, as dictated by your doctor. EEG is important, as we said. And what is an video EEG? Video EEG is where you have the patient's video going on simultaneously with the EEG recording. If they have a convulsive movement and the EEG also shows a spike, that means it is happening. And it is very useful to distinguish between your non-epileptic attacks and epileptic attacks. Non-epileptic, they will be thrashing around, but there will be no discharge on the EEG, right? So this is one of the patterns of bedside EEG that is being done. Now, in diagnosing seizure disorder, which of the following is most beneficial? Obviously, it is the EEG, right? Now, based on the clinical presentation, we will do an MRI or a CSF study. And sometimes you need a toxicology panel like isoniazid levels or tricyclic antidepressants, even alcohol, etc., may cause seizures, right? Now, a 36-year-old alcoholic arrives in the emergency with GTCS and of a GCS of 9, pupils unequal. What test will you order? ABG, CT scan, CBG? Which one preferably, or all of the above? I would say all of the above, because there is every chance that he may have a subdural, he may have hypoglycemia, he may have hypoxia, so all of the above. Now, what are the treatment? Let's come to the treatment pre-hospital. Suppose you are still not received the patient in the hospital, say you are just outside the hospital. Recognize, we are talking about status epilepticus now, because that is how the pre-hospital management of status epilepticus is important, right? So you have to recognize that he is not becoming normal within a few minutes time. Emergency treatment is with benzodiazepines along with assessment of the ABCs. Use airway adjuncts like LMAs or supplemental oxygen, or if required, if you want to use a mask oxygen, also you can use that. Hypoglycemia should be corrected along with IV thiamine, right? Because often alcoholics present with hypoglycemia, and before you give the dextrose, you have to give the thiamine. Otherwise, the brain damage will be there. Midazolam, you can even use IM or pararectal diazepam in case of, especially in children. So lorazepam starting dose adults is 4 milligram. You can repeat to a total of 0.1 milligram per kilogram. And if they don't respond, you consider another shot of lorazepam. Now, after 5 to 10 minutes, you can use another benzodiazepine in the emergency department. But of course, you have to be very careful about the airway, about respiratory depression, as well as hypotension. Now, non-invasive airway protection and gas exchange with head end positioning means you raise the head end up a little, at least 30 degrees. You should do it immediately, clear the airway, suctioning, and administer oxygen. Intubate if necessary and secure oxygenation, ventilation, vital signs. Put in an IV cannula and start IV fluids, vasopressors if required. Do glucose. About glucose, I've already talked about. Benzodiazepines, I've talked about. Fluids, you can start immediately. And with anti-epileptic drugs, you may choose according to your doctor's direction. Most of us use levetiracetam as the first drug of choice. Phenytoin is almost out because of its known complications. Phenytoin is used by some centers, but for by and large, it is levetiracetam. So that would stop the seizure in most cases. And then you can evaluate neurological examination for mass lesions or localization, any hemiparetic side. And you can identify the metabolic conditions of hyponatremia, etc. Suppose they don't respond to the first anti-epileptic drug. Then, depending upon their response, you can choose the second drug. Of course, you must put the urinary catheter in place as early as possible and ask for a EEG. Of course, continuous EEG is a luxury in most of the cases, and not in all neurocritical care units you have continuous EEG, right? And of course, the brain imaging and the CSF study follows. So if you go on having a patient for 10 to 20 minutes still seizing, then the next line of drugs, you must control the seizure within 60 minutes. That is the goal. Now, these are the dosage of drugs which you will find in all textbooks. So I'm not going into detail. And refractory status epilepticus, if the patient does not respond, or most of them want to intubation, ventilation, IV midazolam or propofol infusion. And if in nowadays ketamine is a little higher up on the rank, because there are many, it acts on NMDA receptors, so it acts well. Whereas the midazolam and all will act on the GABAergic receptors. So you can break the cycle of seizures, right? Now, propofol, you have heard about propofol-related infusion syndrome. What constitutes it? Rhabdomyolysis, metabolic acidosis, cardiac or renal failure, And which one? And or is it all of the above? Anyone? It causes everything, you know. Now, let us, these are once again the dosage of the drugs, and I'm not going to details because you will get it in all the uh, major textbooks. And alternatives for refractories, often we use corticosteroids as well, or inhaled anesthetic agents, and even IVIGs are sometimes given. You know, along with that, you have to treat other conditions, like you have to address the diet. Sometimes ketogenic diet is used, and always treat the fever, because fever in the neurocritical care unit is a no-no, right? And actually, you need a continuous EEG to find out how you will stop, because sometimes, even if there are discharges on the EEG, but the patient is clinically stable, we do not overtreat, right? If there it is, the seizure control is for 24 to 48 hours, then you slowly withdraw the continuous infusion of midazolam or propofol, and you add on the other maintenance dosage of the other drugs like levetiracetam, lacosamide, etc. Now, when do you want a continuous EEG? In status epilepticus, where they don't return to baseline more than 10 minutes, or in case of post cardiac arrest patients, or there are continuous discharges, you know, or the patient has a bad traumatic brain injury or subarachnoid, then most often we ask for, but then it is expensive, right? And when will you stop? Says when there is no seizure activity, and the burst suppression at about 8 to 20 seconds interval is what we aim for. That is when you stop the continuous monitoring. Now let us come to the, suppose this patient needs to be transported to the CT scanner machine or an MRI, then all these continuous infusions should be continued during transport, and do not miss the doses of the scheduled maintenance drugs as scheduled for long procedures during transport or during neuroimaging. So you must take the MRI compatible syringe pumps, etc., and the ventilator, transport ventilators, or MRI compatible, pulse oximeters, etc., monitors. And you may need to have vasopressors also, because if your patient is on propofol or midazolam infusion, the blood pressure may fall. What happens in pregnancy and seizure? Now, depends upon, you want to save the mother as well as the child. So lorazepam and all are safe, but usually levetiracetam is also safe, but not safe is the valproate and phenytoin. So lev is a good choice. And in case of eclampsia, of course, that is seizure related only to pregnancy, then magnesium sulfate is a drug of choice. Of course, in pregnancy, you're not going to jump to get a CT scan and etc. done, right? What are the complications of the patient who is continuously having convulsions or seizures? They might suffer from physical injury like long bone fractures or lacerations, etc. They might suffer from hypoxia, because if the patient is continuously seizing and you are not looking at the airway or the oxygenation, and you've not attached any supplemental oxygen or intubated the patient, they can suffer hypoxic brain damage. Now, related to medicines, there are a lot of medicines which cause drug-induced liver injury or delay, like phenytoin or valproate. Ammonia levels can be very high with valproate, and there is a new drug called perampanel. But this hyperammonemia, if you don't pick up, then this itself will lead to a vicious cycle of seizure again and again. So we need to address that. Lacosamide can cause bradycardia. So that is why we look at the heart rate always. And phenytoin can cause multiple cardiac arrhythmias. So these are the complications when you should look for. And phenytoin, in IV phenytoin is notorious to cause, if extravasated, then that can cause a lot of damage, right? So this is one of the pictures of phenytoin extravasation. This patient had almost big abscess, necrosis, and needed plastic surgery as well. So be very careful if you are using IV phenytoin. It's of utmost importance. So in short, what we have learned is that in case of a patient with epilepsy, and obviously the patient in the neurocritical care unit comes with status epilepticus, aggressive management is necessary. Benzodiazepines are used, but you should use it at the proper dose. An EEG is part of the workup, obviously. Parallelly, please do the diagnostic workup as in when time permits and circumstances allow, so that you zero in on the cause of the seizure. The medication levels should be monitored, and always uh, look for drug interactions, hepatic renal dysfunctions, etc. Medications have to be administered at the proper time. You know, if the levetiracetam is dosed at 10 o'clock in the morning and 10 o'clock in the evening, then it has to be 10 and 10, or maybe 15-20 minutes or either side, but not more than that. It cannot be at 12 o'clock because the drug level will fluctuate. So be sure that your medications are administered. If you are giving some enteral medication through the Ryle's tube, ensure that you flush the Ryle's tube so that the entire dose goes in. Otherwise, it sticks to the tube and the patient does not get the adequate blood level. These are the things, nuances in case of nursing, which we need. No, I think I'll stop over here. If there are any questions, then I will try to answer those questions. Hello.
Yes, ma'am.
Is there any question? Does anybody want any clarification?
I'm still no one no one type in the chat box. So we will wait for 2 minutes. If there is not any question, then we will continue.
Yes, sure. How many are there students today?
In this session, there is 8 attendees are there, but in the Facebook, we have 117 views.
I see.
Okay, ma'am. So there is not any comments in Facebook also. So please, ma'am, conclude the session.
Okay. Thank you, ISCCM, for this opportunity of sharing some experiences with the nursing students. I hope they have benefited or learned some things. And I would be happy to explain or discuss later on if they want. I think we can do that. Thank you so much.